welcome. I'm Marin. In this video, we aim to help you translate genetic research into your clinical practice and spotlight how other medical professionals, especially genetic counselors, can be helpful additions to your care team. First of all, what is psychiatric genetics? This field studies the heritable genetic components of mental illness. Uncovering the genes that contribute to these illnesses will hopefully allow for more precise diagnostics and improved treatment. While this field is advancing all the time, it is important to keep in mind that many of the benefits of genetic research for clinical practice are still some years away. Now, are neuropsychiatric disorders heritable? Very much so, but it's more complex than your basic Punnett square. Heritability describes what proportion of a condition's presentation is determined by a patient's genetic makeup. You may regularly see evidence of the heritability of mental illness in your practice, with multiple people in the same family affected with the same psychiatric condition. This is an underlying reason why taking a family history is such an important part of the standard psychiatric interview. Family, twin, and adoption studies have provided strong statistical evidence for the heritability of a condition, or how genetic it is. These studies have conclusively demonstrated that environmental factors alone, like drug abuse or childhood trauma, can't fully account for the development of mental illness. Psychiatric conditions where we see higher concordance rates among identical monozygotic twins suggest a greater genetic contribution for that condition. These kinds of studies show that for schizophrenia, autism spectrum disorders, bipolar disorders, major depression, attention deficit hyperactivity disorder, and panic disorders, the largest transfer of disease risk is heredity. But overall, estimates of heritability vary by the condition and by the study reporting the results. This means we end up with a range of heritable risk, from approximately 40% for major depression to greater than 80% for schizophrenia. But no psychiatric condition has a heritability of 100%, and this is because environmental factors do play a significant role in the manifestation of any of these diseases. Now, all major psychiatric diseases, and really the vast majority of human traits and diseases, are genetically complex. There isn't a clear relationship between one single pathogenic variant and an established disease presentation. Now, strap in because we're going to dive into some genetic terminology here. That term I just used, variant, describes a change in a DNA sequence. Polygenic means that there are multiple genetic variants across the genome, all contributing to the susceptibility to a condition. Mental illnesses are both polygenic and multifactorial. Multifactorial inheritance means that both genetic and environmental factors are interacting together to result in clinical symptoms. Polygenic conditions like mental illnesses don't follow standard Mendelian inheritance rules, like autosomal dominant or recessive patterns. And this is what makes psychiatric genetic tests for molecular diagnosis so difficult to develop. Also, genetic tests can't account for those non-genetic environmental factors that are definitely contributing to the clinical presentation of a disease. You may have also noticed in your patient's family histories that psychiatric disorders don't breed true, as previously thought. Until recently, it was believed that certain psychiatric disorders clustered in families due to shared risk loci. For example, it appears that the first-degree relatives of bipolar patients carry an increased risk not just for developing bipolar disorder, but also for developing unipolar depression, schizoaffective disorder, and other mood disorders. Relatives of schizophrenic patients have similar risk estimates. They're more likely than the general population to be diagnosed not only with schizophrenia, but also with bipolar disorder, major depression, and various anxiety disorders. Some inherited variants implicated in autism also appear to increase the risk of other conditions, particularly major depression, ADHD, and schizophrenia. Keeping in mind that there may be environmental aspects to consider with these comorbidities, all of this overlap in heritability signals that these disorders, which we categorize as clinically distinct from one another, may in fact be genetically linked. While studies support the idea that many disorders share genetic factors, our understanding around the relatedness of different psychiatric disorders is going to continue to evolve. And keep in mind, when it comes to genetic overlap, genetic variants may have opposite effects in the development of certain psychiatric disorders. Like, one variant may be contributory to a certain condition, while at the same time being protective against another. let's take a look at an example. In this pedigree of a family's psychiatric history, Sue has a diagnosis of anxiety and depression, and Ben has a psychosis disorder. This means that their child carries a greater risk of developing either of these disorders compared to the general population. Due to the heterogeneity of mental illness, Sue and Ben's future child may also be at elevated risk for other conditions that aren't seen in their family history. So, what does this mean for your patients? After a new psychiatric diagnosis, you may be flooded by patient questions beyond the scope of their treatment and medical management. Like, is this my fault? How did I even develop this? And will I pass this condition on to my children? More recently, patients have even begun to request commercially available pharmacogenomic testing, but we'll go deeper into that later on in this video. These are all situations where it would be ideal to consult a genetic counselor, both to support your clinical practice and to support the individual patient. So what role does a psychiatric genetic counselor play? Genetic counselors can introduce the biological explanation for psychiatric episodes. Becoming familiar with the idea of the complex causes behind mental illness and that its inheritance is both multifactorial and polygenic can be really valuable to both patients and their worried relatives. A consult with a psychiatric genetic counselor may help some patients adapt to a difficult diagnosis, may help them feel a greater sense of empowerment around their diagnosis and their treatment, or resolve some of the stigma and guilt they may carry as a psychiatric patient. Overall, understanding the biological basis of a mental illness may not only increase your patient's perception of positive regard, but can also improve their openness to professional care and their compliance to their recommended treatment. Genetic counselors can also clarify the risk of developing mental illness to family members. Patients and their families can often overestimate or underestimate this risk based on misconceptions they may have around the cause of their condition. Now, how do psychiatric genetic counselors go about explaining something this complex to patients and their families? It starts with a jar. The jar model, developed by a group of genetic counselors at the University of British Columbia, can be used to explain how disorders can arise from complex inheritance patterns. The jar represents someone's overall lifetime risk of developing mental illness. It needs to be filled to the top for the individual to experience psychiatric symptoms. The yellow circles represent inherited genetic risk factors, and the blue triangles represent environmental risk factors. It's important to remember that children don't necessarily have the same exact risk as their parents or siblings. Instead, they inherit a range of risk. For example, an individual born with a smaller amount of genetic risk will need a greater amount of environmental risk factors to experience a psychiatric episode, while an individual born with a larger genetic risk will only require a small amount of environmental stressors to experience psychiatric symptoms. But even if an individual has a large amount of genetic risk, this doesn't mean that they will definitely develop a psychiatric illness. It's best to see these individuals as being more sensitive to the effects of stressful experiences. Remember, having a strong family history or many genetic risk factors never guarantees that mental illness will occur. A genetic counselor will also be able to communicate the importance of protective factors, even in a situation where lots of risk is determined genetically. These are tools like conscious stress reduction, meditation, psychotherapy, medication, social support, exercise routines, and other learned coping techniques. These can be added to a patient's life to decrease their likelihood of having a psychiatric episode. It's kind of like adding height to the top of the jar, making it less likely the jar will reach full capacity. Even individuals who have already experienced an episode of mental illness can use protective factors to reduce their chance of future symptoms. But remember, protective factors are not a lid that eliminates all risk. So what are some risk estimates that genetic counselors may give to patients? Generally, it's understood that having a first-degree family member affected by a mental illness is a significant risk factor for developing one yourself. After collecting a family pedigree and determining if there's a pattern to any familial diagnoses, psychiatric genetic counselors can customize their probability estimates that a psychiatric illness will arise in currently asymptomatic or unborn relatives. Since it's not yet possible to test whether an individual has specific genes that increase their chances of developing schizophrenia, for example, genetic counselors use empiric data coupled with the client's psychiatric, medical, and family history. These recurrence risk estimates depend on degree of relatedness, but they can't completely account for all possible family situations or the role that other environmental factors may play. For an individual with bipolar disorder, genetic counselors interpret the research data to quote an estimated 5 to 18% lifetime risk for all first-degree relatives of this individual of developing bipolar disorder themselves. This is compared to the general population's risk of up to 5%. The patient's medical and family history would then also be taken into consideration, and this would adjust the range of risk to their specific situation. Genetic counselors will also be able to explain the technical genetic architecture of major psychiatric disorders if your patient has questions about this. Researchers often categorize genetic variants into those that are rare in the population versus those that are common in the population. This popular diagram is an oversimplification of the true relationship between variant frequency and effect size, based on the general pattern that rare variants tend to play a larger role in the development of disease than variants found commonly throughout the population. Even though we do see this pattern, it's important to note that whether a variant is rare or common doesn't necessarily indicate how large or small the effect of that variant will be in affecting disease risk. But the majority of risk alleles associated with human diseases are common variants found throughout the population that we believe are detrimental only in combination at a sufficient threshold. This concept can be translated into a more detailed version of the JAR model. Common genetic variants are defined as those with a prevalence of 1% or greater in the general population. Research looking for these types of genetic variants has shown that there is significant overlap of variants associated with certain conditions. This means that the same common variant could increase risk of both schizophrenia and bipolar disorder. Now, in contrast, rare genetic variants are present in less than 1% of the general population. Rare variants that significantly disrupt gene or protein function may have a larger effect on disease vulnerability than more common variants do. While rare pathogenic variants can be inherited, some cases occur de novo. This means they occur at random in a developing sperm or egg, and they aren't present in either parent. And as a result, you may not initially recognize an obvious familial pattern for these affected individuals. Both de novo and inherited rare variants in certain regions of our genome are likely to be associated with multisystemic syndromes, and this may have implications for the way an individual's condition should be managed. For example, a chromosomal deletion at 22q11.2 most often arises de novo. The empirical risk for schizophrenia in patients with this deletion is highly clinically notable. Roughly 30 to 40% of these individuals develop psychosis that is clinically indistinguishable from the general non-syndromic psychosis population. It's estimated that approximately 1% of schizophrenia patients have this deletion syndrome. While it's true that most psychiatric illnesses are multifactorial and genetically complex, some conditions that are traditionally considered Mendelian may also confer a risk of developing psychiatric illness as a clinical feature of this syndrome. If you suspect your patient has a multisystemic phenotype, congenital anomalies, an intellectual disability, epilepsy, or an autism spectrum disorder, you should consider whether your patient may benefit from referral to genetic counseling for genetic testing. These are just a few examples of diagnoses that may result from a genetics workup of a psychiatric indication. So, what developments should psychiatric clinicians like yourself anticipate in the coming years? To recap, evidence from psychiatric genetics research supports the idea that a complex genetic network can contribute to disease development. This may involve many genes within large pathways that play a role in disease phenotype when interacting with environmental factors. Understanding how these genes work together as a system can better explain how protein interactions, neuron signaling, and other molecular mechanisms result in the development of psychiatric illnesses. One tool with a potential role in future clinical decision-making is the polygenic risk score. Like other genetic tests, polygenic risk analysis can't account for non-genetic environmental factors, but they can look at the heterogeneic nature of mental illness. PRS attempts to calculate a single estimate of disease from the combined effects of multiple risk loci on cell development and behavior. PRS doesn't fulfill the need for conclusive molecular diagnostic tests, but in the future, it may offer the ability to stratify high-risk versus low-risk patients. Now, at the time of this recording, PRS algorithms aren't accurate enough to use as a diagnostic tool or as a therapeutic decision-making aid. PRS is commercially available, but these tests haven't yet been externally validated as clinically actionable, and they definitely can't determine exactly who will and will not develop a mental illness. But this is an active area of research, and some in this field are optimistic that PRS will eventually offer clinical potential for disease surveillance and early intervention, especially for high-risk individuals. Now, what about pharmacogenomic testing? As you may have noticed, commercial pharmacogenomic testing is now commonly advertised to the public, who may be aware that only 30% of psychiatric patients report successful first-line treatment. The goal of pharmacogenomics-guided treatments is to avoid adverse drug reactions and improve the efficacy of medication. These tests often advertise that they analyze genetic markers for genes involved in drug metabolism. The goal of this is to inform medication selection and dosage. One example is the cytochrome P450 enzyme system, which is involved in the metabolism of more than 80% of manufactured drugs, including several antipsychotics. PGX can be extremely useful in other fields, especially when selecting blood-related medications like warfarin and cancer therapeutics. But as of 2021, the International Society of Psychiatric Genetics does not yet consider the clinical utility of these reports to be sufficient in psychiatry, and the cost-effectiveness of PGX-guided treatment is still up for debate. You may have seen initial PGX studies that have successfully reported predictions of a patient's susceptibility to severe adverse drug reactions like clozapine-induced agranulocytosis and neutropenia, but these variants aren't yet robustly correlated enough to produce a predictive genetic test. In February of 2020, the director of the US FDA announced a new review of the current science in pharmacogenetics, saying that the landscape of these laboratory-developed tests has changed significantly since earlier and simpler technologies. And yet, the FDA's oversight framework has remained the same and without much regulatory oversight of this industry. Currently, only the most scientifically backed justifications for pharmacogenetic testing in psychiatry should be considered, and only when the drugs being considered as treatment options are listed on the FDA's table of pharmacogenetic associations. As this commercial field rapidly expands and evolves, there's clearly a need for improved standards across regulatory bodies. Your patients may still have questions regarding PGX information they find on their medication labels, despite this FDA warning. And this is where a psychiatric genetic counselor can be of great help. They can discuss the limitations of PGX for psychiatry with your patient, as well as informing them of any related clinical trials that may be pertinent to them. So, let's wrap up everything we've covered. Many of the major psychiatric disorders are highly heritable, reflecting a strong genetic component. But the genetic architecture and the mechanisms of each disease are highly complex. Variables like gene-environment interactions are still being untangled, and many neurodevelopmental and psychiatric disorders have both genetic and clinical heterogeneity, as we can see here with 22q11.2 deletion syndrome. In this example, many different genetic modifications can manifest as autism symptoms, and one specific genetic variant can manifest as a variety of psychiatric symptoms. As the 2000 World Health Organization Bulletin reflected, too simple was the concept, born of early pharmacological successes, that abnormal levels of one or more neurotransmitters would satisfactorily explain the pathogenesis of depression or schizophrenia. Gone is the concept of the causative gene, replaced by that of genetic complexity. Genetics should yield new therapies aimed not just at symptoms, but also at pathogenic processes. All of this may seem daunting from a clinical perspective, but ultimately, this more nuanced outlook will allow the eventual realization of precision medicine for individual patients. New analytic methods, such as polygenic risk scores, are also being applied more and more often in research, and they may eventually become clinically useful. Pharmacogenomic tests may provide for the application of future precision medicine in psychiatry and will hopefully improve patient care after further development through clinical trials. Ultimately, involving a genetic counselor in your practice can improve patient care as they adapt their psychiatric diagnosis and can help you navigate the complexities of incorporating genomic developments into your clinical care. We hope you've enjoyed this video and that you'll find it helpful. If you have any further questions, then please refer to these resources and contacts, and thank you very much for watching.